Hey guys, Scott and Ivo here today to talk all about rocker bottom shoes. Hey guys, Scott and Ivo, the Gate Geeks here to talk about rocker bottom shoes. Ivo, how are you doing?
Doing pretty good. Wishing we had a little more snow out here in Colorado, but it is what it is.
It is what it is. So today we're going to talk about rocker bottom shoes. The how, the when, the why, the who, all the good questions here to answer. But is it something that you use quite often in your practice, or is it something more of a case-by-case selective kind of utilization?
A little bit of both. First of all, a lot of what we're talking about today, if you want to check out an article, it's a freebie. Scott will put the link in the show notes. There was an article in Lower Extremity Review, which if you don't subscribe to, you should. It's free online journal. This is from March 2017. It's an oldie but a goodie. The information really doesn't change. But to answer your question, yeah, we use rocker bottom shoes for certain conditions: hallux limitus, sesamoiditis, triple arthrodesis, things like that, where we need to basically help that person to either get more ankle or more forefoot rocker. But before we do that, Scott, why don't you talk about what a rocker bottom shoe is?
Sure. A rocker bottom shoe is exactly what it sounds like. It's a shoe that has a rocker, and by a rocker, it's almost like how to describe a rocker. It has almost like a curved type of surface to the bottom of it, and allows the foot to be protected in certain areas and facilitate movement in other areas. Things you got to consider is the angle, the location of the rocker. Those are key components of determining what the rocker would be used for and who may benefit and where the risk benefit ratio may come in. But basically it's a curved surface in most cases on the bottom of the shoe that facilitates motion in certain areas and stops motion in other areas.
Why don't you pull that picture up real quick so we can show folks what rockers look like? So the thing about a rocker bottom shoe, or a banana bottom shoe, as we like to call them in the office a lot of times, it's sort of like Masai barefoot technology. I don't know if you guys remember, if you're old enough to know when that stuff came out. But first of all, it's a silly name because the Masai people don't wear shoes. But the second thing is that it was this shoe that had the whole bottom of it was rockered. And then Skechers kind of came up with a less expensive version of a rocker bottom shoe. The problem with that shoe is the entire bottom is rockered from the heel all the way to the forefoot. So sort of like in this picture in the lower left-hand corner where it says heel rocker, the whole bottom of it is rounded like that. The cool thing about a rocker is you can pick where the shoe moves. And a lot of times you want that rocker near the toe break where that shoe is going to flex up in the front, but it's got a stiff front end. So what it does is it precludes that person from having to dorsiflex their hallux during terminal stance. So in other words, they don't have that forefoot rocker that we would normally see, or if a person has that absent, then the shoe can make that up for them. The big thing, like Scott alluded to, is we have to make sure that whatever your line of progression is, in other words, whatever direction you're moving in, right? Or your foot is moving in, I should say. So if you have external torsion, your feet are a little bit abducted, if they're internal torsion, they're adducted. You want that rocker to try to be perpendicular to that line of progression. That way you're going to get the most out of it. And some rockers, you're going to have to take into your lab and you're going to have to skive the rocker because the rocker is just perpendicular to the sole of the shoe. And it actually needs to maybe see like at a 30-degree angle or a 15-degree angle or something like that. So if you have a grinder available to you, in your office, which I'm sure a lot of you do, you can go ahead and you can actually alter that. Or you can take a shoe and you can make the rocker be more of where you want it to be. The only problem with that is that you're going to grind off some of the outsole, of course. And as you're doing that, they're going to lose a little bit of traction. But it can be a super handy tool to do that. You're going to see this mostly on maximalist type shoes that are going to have, say, a ramp delta or a forefoot drop of, say, 26, 28 millimeters or greater. So you're looking at the Hokas, the Olympuses.
You're talking stack height there too. Correct?
Stack height. Yeah, I'm sorry. That's what I meant to say there. But we're looking at some of those shoes like the Olympus, like the Spectre. that's made by Topo, shoes like that are going to have a lot of that. But a stiff front end and rocker. And remember that the shoe doesn't have to be thick. Like a hiking boot might have a thin sole, but if it's stiff, that's going to act like a forefoot rocker.
Mm-hmm.
So we've been talking about how rocker can be good for making up for motion we don't have, largely great toe or hallux dorsiflexion as well as ankle dorsiflexion. But Scott, what are some of the other applications that you use in your office you use rocker shoes for?
Yeah, no, I think you hit the big one for me. The big one I use it for is a first MTP hallux rigidus situation. That's where I tend to find it the most. But I've used it in case of a Liz Frank injury, where the midfoot, you want to protect the midfoot a little bit. If somebody's got a really hypermobile type of a hypomobile type of foot, and you need to try to facilitate more motion through given areas, we talked offline a little bit about fusions. Those are great implications or reasons why a rocker shoe would be implemented. We talked about even getting somebody to run that has very limited motion in their foot due to fusions, etc., coalitions, etc. A rocker shoe can facilitate that, but there are risks associated with that. Ivo, why don't you talk about what some of the risks are?
So some of the risks are minor and major. The minor risks are if the rocker's in the wrong place, the joint that you're trying to offload is not going to be offloaded. In fact, sometimes it's actually loaded to a greater degree. Think about where the toe break is in a shoe. In other words, where that great toe dorsiflexion should be. If that axis of toe break is before or after the first MTP, a lot of times the person's going to have first MTP pain. Well, no difference with the rocker. Where that is going to make a huge difference. The other thing with rockers, because they have a tendency to throw you onto your forefoot, is it's going to load your knee more. So if you have a person with an acute knee injury and you're trying to not load the knee, a rocker shoe may not be the best choice for them. It's going to force them into more knee flexion as they're going forward. However, if you had somebody with an Achilles tendinopathy, where you're trying to offload the Achilles and load the knee to a greater degree, then it could be a real boon. Scott, how do you determine where the rocker should be in a shoe?
That's a great question. And before I dive into that, I'll just say this: there's no risk, no change, without consequence, right? So, a lot of times when I'm implementing even an orthotic, and there are cases, and we can go down this rabbit hole too. There are cases where a rocker bottom shoe works very nicely with or in conjunction with an orthotic, right? They can work hand in hand. But if you are shifting the load, in the case of, say, a rocker bottom shoe, that load is being absorbed by somewhere else in the body, and oftentimes in this case, the knee is the main culprit that tends to see that added effect. So just be aware that these are typically used for short-term implications, not usually used for long-term uses. Now, obviously, in the case of a fusion or a coalition where somebody has no motion, these can definitely be beneficial, but be wary or be aware that there are some added areas that may take up that load a little bit more to deal with that. So where does the rocker go? I think you have to be mindful of, again, what area you're trying to facilitate and what area you're trying to protect. If you're trying to protect the midfoot, let's say, then you don't want that rocker rolling through the midfoot. You want that area to be more stable through the midfoot. You want to get the motion where the motion is able to be garnered, and then you want to protect the area that needs to be protected. So allowing that rocker bottom to occur through that area where there's little to no motion is typically where I would go with that.
Yeah, so you can simply just look at the shoe, have the person stand next to the shoe or whatever, looking at it from the side, kind of like we are in this picture here. Determine the area of hypomobility, the area that's not moving, the area that we're trying to get that motion, and the central axis of the rocker should be in there. Now, not all shoes are going to match perfectly, just like with toe breaks and everything else. So you may have to either, one, select a different shoe, or two, modify the shoe for the individual in the office if you feel comfortable doing that. We don't really have a video on shoe mods yet, but that will be forthcoming. At some point, we do have the big orthotic program where we show you how to do all of the different modifications to orthotics and stuff like this. Scott, you alluded to using a rocker can pair really nicely with an orthotic. Can you give us an example of how you would do that? I have my own in my head, but give me an example of how you would do that and where you think that would be beneficial.
Sure. So for me, I've used it in the case where, let's say somebody's got a rigid midfoot or a midfoot that doesn't move very well, hypomobile midfoots, and the arch is fairly high, and I want to dissipate the force on the arch. The shoe itself isn't going to offer that contact or pressure dispersion inside the shoe. So I'll go in with a total contact orthotic to help dissipate the force inside the shoe, and then use the rocker at the bottom to help facilitate more motion through that midfoot. Does that make sense? So is that something that you commonly do as well?
Absolutely. That's one application that we certainly do. And then another one was sort of an unusual application that we do. Let's say you have an individual with a hallux limitus, but when you plantar flex the distal first, you can get more range of motion out of them. So a lot of times what we'll do is we'll use something like a first ray cutout, which drops the head of that first in conjunction with the rocker, which forces that motion to a little greater degree. Of course, it's not going to be a super aggressive kind of rocker. We're talking about something with the stack height probably between 23 and 28 millimeters as far as that. But that a lot of times will just provide that little extra impetus to get that person through that range of motion. Because remember, it's about trying to preserve as much range of motion as we possibly can, getting that joint to go through that normal physiological range. And we have to think about, the mechanics of what is supposed to happen. A good test for that is just when you have the patient in front of you with their shoes off, put your index finger underneath the arch, place your thumb at the distal aspect of the first, press up on your finger, down on your thumb, and then dorsiflex the toe. If that amount is greater than when the person's foot is neutral or weight bearing, they could probably benefit from something like that, where we're going to try to sync that first row. If that range of motion is the same or less, then that's a case where we would not want to use a first ray cutout unless we're trying to create a raging pain on the back of the first MTP.
The other thing that we probably should mention before we kind of dive off here is, some of the added benefits from a rocker shoe with regards to energy expenditure. The rocker bottom shoe offers a sense of instability, which can be good and can be bad, right? If you put somebody, an older adult, let's say with some balance problems, into a rocker bottom shoe, are you maybe putting them at greater risk for fall? Potentially. But you're also increasing the energy expenditure, working on the proprioceptive system a little bit more. So, Ivo, this is an area that you love to talk about. Why don't you dive into that a little bit?
Yeah, so rocker bottom shoes, like Scott was alluding to, can certainly change the proprioceptive input to the foot. So depending upon, again, where that rocker is, it can be a boon or a bane to rehab. So using them for short periods of time with individuals that have balance difficulties. As we age, we have a tendency to lose our mechanoreceptors, both the ones in our joints as well as the ones in our muscles, through largely atrophy, but sometimes injury and those sorts of things. So what we need to do, since they're not going to regenerate, since neural tissue really doesn't regenerate, we need to take what's left and make the best of that. So you can use a rocker bottom shoe more as a rehab aspect for short periods of time. The MBT shoe, or something like a Skechers, I forget what it's called, push-up, something like that, can be used because the entire bottom of the shoe, again, is like this lower left-hand picture here, the heel rocker. The whole shoe is a little bit more unstable. So putting the person in that and having them, say, walk around in a safe environment, use a walker, grab 2 ski poles, grab 2 hiking poles, and work with this for short periods of time. Proprioceptive exercises are very taxing on the brain because we're using the 3 different systems that keep us upright in the gravitational plane: our visual system, our vestibular system, and our mechanoreceptors, or our proprioceptive system. So as our proprioceptive system starts to fail, which proportionally should be the greater amount of what we're using, we tend to become more visually dependent, unless, of course, you have cataracts and your eyes start to fail, and then you have to become more vestibularly dependent. So you can train that system, as long as we're sort of on a flat planar surface with our rockered shoe, to work somewhat better and actually rehab the right system. So they can be used sparingly. in the right circumstances. And then that individual will slowly work their time up so they can wear it longer and longer. Some people wear them all day long. There was another shoe, Scott, you're probably familiar with this. Remember the Z coils that
I do.
had the little podium in the back that was on a spring,
Yep.
and that created a lot of instability too. A lot of sprained ankles as well from people that were using the shoe inappropriately. So the other thing to take into consideration, if you're going to use a rockered shoe for proprioceptive rehab, you want to look from the back part of the shoe. So if you're staring at the shoe from the posterior, that the outsole goes faster than the heel counter, or goes lateral to the heel counter. So in other words, it's a wider base of support. So that way the rocker's only in one plane, the sagittal plane, AP, rather than in multiple planes. When the heel is the same or narrower than the heel box of the shoe, in other words, the back heel counter, then that creates further instability, which, if that's what you're trying to create, is a good thing. But if you have somebody with like chronic ankle instability or something like that, and you're sticking them in that, that would be certainly a precautionary measure we'd have to take.
Right. Awesome. Well, again, rockers, the take-home message here is that there's a time and a place, right? They're not for everyone. They're not for all situations. They're not the necessarily my go-to for everything, but there are certain situations where they can be used to help offload certain areas, to help improve gait mechanics, to help even challenge, like we were talking about, the vestibular system a little bit, and can be another tool in your toolbox that you can utilize to help your foot and ankle patients with pathology. Anything to close with, Ivo?
That's it. You've said it all. We'll see you guys next time. Thanks.
Take care, guys.